Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Sacral Neuromodulation versus Conservative Treatment for Refractory Idiopathic Slow Transit Constipation, the Randomized Clinical No. 2 Trial. Objective: assess the effectiveness of sacral neuromodulation, SNM, versus personalized conservative treatment, PCT, in patients with refractory idiopathic slow transit constipation, STC. Background: evidence on SNM for idiopathic STC is conflicting and of suboptimal methodological quality. Methods: the No. 2 trial was a multicenter, open-label, pragmatic, randomized trial performed in 2 Dutch hospitals. 67 patients with idiopathic STC, a defecation frequency less than 3 per week and refractory, unresponsive, to maximal conservative, non-operative, treatment were included. Exclusion criteria included outlet obstruction, rectal prolapse, and previous colon surgery. Patients were randomized 3:2 to SNM, n equals 41, or PCT, n equals 26, with randomization minimization between February 21, 2017 and March 12, 2020. In SNM patients, an implantable pulse generator was implanted after a successful 4-week test stimulation. PCT patients received conservative treatments such as laxatives or retrograde colonic irrigation. The primary outcome was treatment success, defined as average defecation frequency greater than or equal to 3 per week, after 6 months. Secondary outcomes included constipation severity, fatigue, quality of life, and adverse events. Analysis was according to intention to treat. Results: after 6 months, 53.7%, patients were successfully treated with SNM versus 3.8%, patient with PCT, odds ratio 36.4, 95% C 3.4 to 387.5, P equals 0.003. At 6 months, SNM patients reported lower constipation severity and fatigue scores, P less than 0.001, and improved quality of life compared with PCT, P less than 0.001. 8 serious adverse events, 6 SNM 2%, and 78 adverse events, 68 SNM 10%, were reported. Conclusions: SNM is a promising surgical treatment option in a homogeneous group of adults and adolescents with refractory idiopathic STC. Quantifying Perioperative Risks for Antireflux and Hiatus Hernia Surgery, a multicenter cohort study of 4,301 patients. Objective: using a comprehensive Australian cohort, we quantified the incidence and determined the independent predictors of intraoperative and postoperative complications associated with antireflux and hiatus hernia surgeries. In addition, we performed an in-depth analysis to understand the complication profiles associated with each independent risk factor. Background: predicting perioperative risks for fundoplication and hiatus hernia repair will inform treatment decision-making, hospital resource allocation, and benchmarking. However, available risk calculators do not account for hernia anatomy or technical aspects of surgery in estimating perioperative risk. Methods: retrospective analysis of all elective anti-reflux and hiatus hernia surgeries in 36 Australian hospitals over 10 years. Hierarchical multivariate logistic regression analyses were performed to determine the independent predictors of intraoperative and postoperative complications accounting for patient, surgical, anatomic, and perioperative factors. Results: a total of 4,301 surgeries were analyzed. Of these, 1,569, 36.5%, were large/giant hernias and 292, 6.8%, were revisional procedures. The incidence rates of intraoperative and postoperative complications were 12.6% and 13.3%, respectively. The Charlson Comorbidity Index, hernia size, revisional surgery, and baseline anticoagulant usage independently predicted both intraoperative and postoperative complications. These risk factors were associated with their own complication profiles. Finally, using risk matrices, we visualized the cumulative impact of these 4 risk factors on the development of intraoperative, overall postoperative, and major postoperative complications. Conclusions. This study has improved our understanding of perioperative morbidity associated with antireflux and hiatus hernia surgery. Our findings group patients along a spectrum of perioperative risks that inform care at an individual and institutional level. Comparison of short-term and 3-year oncological outcomes between robotic and laparoscopic gastrectomy for gastric cancer, a large multicenter cohort study. To compare the short-term and long-term outcomes between robotic gastrectomy, RG, and laparoscopic gastrectomy, LG, for gastric cancer. Background. The clinical outcomes of RG over LG have not yet been effectively demonstrated. Methods. This retrospective cohort study included 3,599 patients with gastric cancer who underwent radical gastrectomy at 8 high-volume hospitals in China from January 2015 to June 2019. Propensity score matching was performed between patients who received RG and LG. The primary endpoint was 3-year disease-free survival, DFS. Results. After 1-to-1 propensity score matching, 1,034 pairs of patients were enrolled in a balanced cohort for further analysis. The 3-year DFS in the RG and LG was 83.7% and 83.1%, p equals 0.745, respectively, and the 3-year overall survival was 85.2% and 84.4%, respectively, p equals 0.647. During 3 years of follow-up, 154 patients in the RG and LG groups relapsed, cumulative incidence of recurrence, 15.0% versus 15.0%, p equals 0.988. There was no significant difference in the recurrence sites between the two groups, all p greater than 0.05. Sensitivity analysis showed that RG had comparable 3-year DFS, 77.4% versus 76.7%, p equals 0.745, and overall survival, 79.7% versus 78.4%, p equals 0.577, to LG in patients with advanced, pathologic T24A disease, and the recurrence pattern within 3 years was also similar between the two groups, all p greater than 0.05. RG had less intraoperative blood loss, lower conversion rate, and shorter hospital stays than LG, all p greater than 0.05. Conclusions. For resectable gastric cancer, including advanced cases, RG is a safe approach with comparable 3-year oncological outcomes to LG when performed by experienced surgeons. The Patient Perspective on Colectomy for Recurrent Diverticulitis, a Qualitative Study. Objective. Understand the patient's decision-making process regarding colectomy for recurrent diverticulitis. Background. The decision to pursue elective colectomy for recurrent diverticulitis is highly preference-sensitive. Little is known about the patient's perspective in this decision-making process. Methods. We performed a qualitative study utilizing focus groups of patients with recurrent diverticulitis at 3 centers across the United States. Using an iterative inductive/deductive approach, we developed a conceptual framework to capture the major themes identified in the coded data. Results. From March 2019 to July 2020, 39 patients were enrolled across 3 sites and participated in 6 focus groups. After coding the transcripts using a hierarchical coding system, a conceptual framework was developed. Major themes identified included participants' beliefs about surgery, such as normative beliefs, e.g., subjective, value placed on surgery, control beliefs, e.g., self-efficacy, stage of change, and anticipated outcomes, e.g., expectations, anticipated regret, the role of behavioral management strategies, e.g., fiber, eliminate bad habits, emotional experiences, e.g., depression, embarrassment, current symptoms, e.g., severity, timing, and quality of life, e.g., cognitive load, psychosocial factors. 3 sets of moderating factors influencing patient choice were identified: clinical history, e.g., source of diagnosis, multiple surgeries, clinical protocols, e.g., pre-op and post-op education, and provider-specific factors, e.g., specialty, choice of surgeon. Conclusions. Patients view the decision to undergo colectomy through 3 major themes: their beliefs about surgery, their psychosocial context, and moderating factors that influence participant choice to undergo surgery. This knowledge is essential both for clinicians counseling patients who are considering colectomy and for researchers studying the process to optimize care for recurrent diverticulitis. Evaluating the impact of operative team familiarity on cardiac surgery outcomes, a retrospective cohort study of Medicare beneficiaries. Objective: to associate surgeon anesthesiologist team familiarity (TF) with cardiac surgery outcomes. Background: TF, a measure of repeated team member collaborations, has been associated with improved operative efficiency. However, examination of its relationship to clinical outcomes has been limited. Methods. This retrospective cohort study included Medicare beneficiaries undergoing coronary artery bypass grafting, CABG, surgical aortic valve replacement, SAVR, or both, CAB plus SAVR, between January 1, 2017, and September 30, 2018. TF was defined as the number of shared procedures between the cardiac surgeon and anesthesiologist within 6 months of each operation. Primary outcomes were 30 and 90-day mortality, composite morbidity, and 30-day mortality or composite morbidity, assessed before and after risk adjustment using multivariable logistic regression. Results. The cohort included 113,020 patients, 84,397 CAB, 15,939 SAVR, 12,684 CAB plus SAVR. Surgeon anesthesiologist dyads in the highest, 31,631 patients, TF median, interquartile range equals 8, 6, 11, and lowest, 44,307 patients, TF equals 0, 0, 1. TF terciles were termed familiar and unfamiliar, respectively. The rates of observed outcomes were lower among familiar versus unfamiliar teams: 30-day mortality, 2.8% versus 3.1%, p equals 0.001, 90-day mortality, 4.2% versus 4.5%, p equals 0.023, composite morbidity, 57.4% versus 60.6%, p less than 0.001, and 30-day mortality or composite morbidity, 57.9% versus 61.1%, p less than 0.001. Familiar teams had lower overall risk-adjusted odds of 30-day mortality or composite morbidity, adjusted odds ratio, AOR, 0.894, 0.868, 0.922, p less than 0.001, and for SAVR significantly lower 30-day mortality, AOR 0.724, 0.547, 0.959, p equals 0.024, 90-day mortality, AOR 0.779, 0.620, 0.978, p equals 0.031, and 30-day mortality or composite morbidity, AOR 0.856, 0.791, 0.927, p less than 0.001. Conclusions. Given its relationship with improved 30-day cardiac surgical outcomes, increasing TF should be considered among strategies to advance patient outcomes. Next article is from Journal of American Medical Association Surgery. Magnetic seed versus Guidewire breast cancer localization with magnetic lymph node detection, a randomized clinical trial. Importance: Guidewires have been the standard for breast lesion localization but pose operative and logistic challenges. Paramagnetic seeds have shown promising results, but to the author's knowledge, no randomized comparison has been performed. Objective: to determine whether the combination of a paramagnetic seed and supraparamagnetic iron oxide, SPIO, is equivalent to Guidewire SPIO for breast cancer localization and sentinel lymph node detection, SLND. Design, setting, and participants. This was a Phase 3, pragmatic, equivalence, 2-arm, open-label, randomized clinical trial conducted at 3 university and/or community hospitals in Sweden from May 2018 to May 2022. Included in the study were patients with early breast cancer planned for breast conservation and SLND. Study data were analyzed July to November 2022. Interventions. Participants were randomly assigned 1-to-1 to a paramagnetic seed or a guidewire. All patients underwent SLND with SPIO. Main outcomes and measures: re-excision rate and resection ratio, defined as actual resection volume, optimal resection volume. Results: a total of 426 women, median, IQR, age, 65, 56 to 71 years, median, IQR, tumor size, 11, 8 to 15, were included in the study. The re-excision rate was 2.90%, 95% C, 1.60% to 4.80%, and the median, IQR, resection ratio was 1.96, 1.15 to 3.44. No differences were found between the guidewire and the seed in re-excisions, 6 of 211, 2.84%, versus 6 of 209, 2.87%, difference, minus 0.03%, 95% C, minus 3.20% to 3.20%, P equals 0.99, or resection ratio, median, 1.93, IQR, 1.18 to 3.43 versus median, 2.01, IQR, 1.11 to 3.47, P equals 0.70. Overall SLN detection was 98.6%, 95% C, 97.1% to 99.4%, with no differences between arms, 203 of 207, 98.1%, versus 204 of 206, 99.0%, difference, minus 0.9%, 95% C, minus 3.6% to 1.8%, P equals 0.72. More failed localizations occurred with the guidewire, 21 of 208, 10.1%, versus 4 of 215, 1.9%, difference, 8.2%, 95% C, 3.3% to 13.2%, P less than 0.001. Median, IQR, time to specimen excision was shorter for the seed, 15, 10 to 22 minutes versus 18, 12 to 30 minutes. P equals 0.01, as was the total operative time, 69, 56 to 86 minutes versus 75.5, 59 to 101 minutes, P equals 0.03. The experience of surgeons, radiologists, and surgical coordinators was better with the seed. Conclusions and relevance: the combination of SPIO and a paramagnetic seed performed comparably with SPIO and guidewire for breast cancer conserving surgery and resulted in more successful localizations, shorter operative times, and better experience. Next, we will be discussing articles from British Journal of Surgery. Monopolar diathermy versus a vessel sealing device for reducing postoperative drain output after simple mastectomy. Randomized clinical trial. Background: electrosurgical devices are commonly used during mastectomy for simultaneous dissection and hemostasis, and can provide potential benefits regarding vessel and lymphatic ligation. The aim of this prospective RCT was to assess whether using a vessel sealing device, LigaSure, improves perioperative outcomes compared with monopolar diathermy when performing simple mastectomy. Methods: patients were recruited prospectively and randomized in a 1:1 manner to undergo simple mastectomy using either LigaSure or conventional monopolar diathermy at a single center. The primary outcome was the number of days the drain remained in situ after surgery. Secondary outcomes of interest included operating time and complications. Results: a total of 86 patients were recruited, 42 were randomized to the monopolar diathermy group and 44 were randomized to the LigaSure group. There was no significant difference in the mean number of days the drain remained in situ between the monopolar diathermy group and the LigaSure group, 7.75 days versus 8.23 days, P equals 0.613, and there was no significant difference in the mean total drain output between the monopolar diathermy group and the LigaSure group, 523.50 ml versus 572.80 ml, p equals 0.694. In addition, there was no significant difference in the mean operating time between the groups. For simple mastectomy alone, 88.25 min for the monopolar diathermy group versus 107.20 min for the ligashore group, p equals 0.078, and simple mastectomy with sentinel lymph node biopsy, 107.20 min for the monopolar diathermy group versus 114.40 min for the ligashore group, p equals 0.440. Conclusion. In this double-blinded single-center RCT, there was no difference in the total drain output of the number of days the drain remained in situ between the monopolar diathermy group and the ligashore group. Impact of type 2 diabetes on complications after primary breast cancer surgery, Danish population-based cohort study. Background. Knowledge is sparse on the impact of type 2 diabetes, T2D, on surgical outcomes after breast cancer surgery. This study investigated the association between T2D and risk of complications after primary breast cancer surgery, and evaluated the biological interaction between T2D and comorbidities. Methods. Using the Danish Breast Cancer Group Clinical Database, a cohort of all Danish women diagnosed with early-stage breast cancer during 1996 to 2022 was created. All patients underwent mastectomy or breast-conserving surgery. Information on prevalent T2D was collected from Danish medical and prescription registries. Surgical complications were defined as hospital diagnoses for medical or surgical complications developing within 30 days after primary breast cancer surgery. The 30-day cumulative incidence proportion of complications was calculated, and Cox regression was used to estimate HRs. Interaction contrasts were computed to determine the additive interaction between T2D and comorbidities on the incidence rate of complications. Results. Among 98,589 women with breast cancer, 6,332, 6.4%, had T2D at breast cancer surgery. Overall, 1,038, 16.4%, and 9,861, 10.7%, women with and without T2D developed surgical complications, yielding cumulative incidence proportions of 16, 95% CI 15 to 17, and 11, 10 to 11% respectively, and a HR of 1.43, 95% CI 1.34 to 1.53. The incidence rate of surgical complications explained by the interaction of T2D with moderate and severe comorbidity was 21 and 42%, respectively. Conclusion. Women with breast cancer and T2D had a higher risk of complications after primary breast cancer surgery than those without T2D. A synergistic effect of T2D and comorbidity on surgical complications can explain this association. Next we will be discussing articles from Journal of Vascular Surgery. Long-term outcomes for hybrid aortic arch repair. Objective. Since its inception in the early 2000s, hybrid arch repair, HAR, has evolved from novel approach to well-established treatment modality for aortic arch pathology in appropriately selected patients. Despite this nearly 20-year history of use, long-term results of HAR remain to be determined. As such, objectives of this study are to detail the long-term outcomes for HAR within an expanded classification scheme. Methods. From August 2005 to August 2022, 163 consecutive patients underwent HAR at a single referral institution. Operative approach was selected according to an institutional algorithm and included Zone 0-1 HAR in 25%, N equals 40, Type I HAR in 34%, N equals 56, and Type 2/3 HAR in 41%, N equals 67. Specific Zone 0-1 technique was Zone 1 HAR in 31, 78%, Zone 0 with innominate snorkel, Zone 0 SHAR in 7, 18%, and Zone 0 with single-side branch endograft, Zone 0 BHAR in 2, 5%. The 30-day and long-term outcomes, including overall and aortic-specific survival, as well as freedom from reintervention, were assessed. Results. The mean age was 63 plus or minus 13 years and almost one-half of patients, 47%, N equals 77, had prior sternotomy. Presenting pathology included degenerative aneurysm in 44%, N equals 71, residual dissection after prior type A repair in 38%, N equals 62, chronic type B dissection in 12%, N equals 20, and other indications in 6%, N equals 10. Operative outcomes included 9% mortality, N equals 14, at 30 days, 5% mortality, N equals 8, in hospital, 4% stroke, N equals 7, 2% new dialysis, N equals 3, and 2% permanent periparesis/plegia, N equals 3. The median follow-up was 44-month, interquartile range, 12 to 84 months. Overall survival was 59% and 47% at 5 and 10 years, respectively, whereas aorta-specific survival was 86% and 84% at the same time points. At 5 and 10 years, freedom from major reintervention was 92% and 91%, respectively. Institutional experience had a significant impact on both early and late outcomes, comparing the first, 2005 to 2012, and second, 2013 to 2022, halves of the series. 30-day mortality decreased from 14% to 1%, p equals 0.01, and stroke from 6% to 3%, p equals 0.62. Improved operative outcomes were accompanied by improved late survival, with 78% of patients in the later era versus 45% in the earlier era surviving to 5 years. Conclusions. HAR is associated with excellent operative outcomes, as well as sustained protection from adverse aortic events as evidenced by high long-term aorta-specific survival and freedom from reintervention. However, surgeon and institutional experience appear to play a major role in achieving these superior outcomes, with a 5-fold decrease in operative mortality and a 2-fold decrease in stroke rate in the latter half of the series. These long-term results expand on prior midterm data and continue to support use of HAR for properly selected patients with arch disease. A dedicated risk prediction model of 1-year mortality following endovascular aortic aneurysm repair involving the renal mesenteric arteries. Objective: treatment goals of prophylactic endovascular aortic repair of complex aneurysms involving the renal mesenteric arteries, complex endovascular aortic repair, SAVAR, include achieving both technical success and long-term survival benefit. Mortality within the first year after SAVAR likely indicates treatment failure owing to associated costs and procedural complexity. Notably, no validated clinical decision aid tools exist that reliably predict mortality after SAVAR. The purpose of this study was to derive and validate a preoperative prediction model of 1-year mortality after elective SAVAR. Results: the overall crude 1-year mortality rate after elective SAVAR was 11.3%, N equals 456,4053. Independent preoperative predictors of 1-year mortality included chronic obstructive pulmonary disease, chronic renal insufficiency, creatinine greater than 1.8 mg/dl or dialysis dependence, hemoglobin less than 12 g/dl, decreasing body mass index, congestive heart failure, increasing age, American Society of Anesthesiologists class greater than or equal to 4, current tobacco use, history of peripheral vascular intervention, and increasing extent of aortic disease. The 1-year mortality rate varied from 4% among the 23% of patients classified as low risk to 23% for the 24% classified as high risk. Performance of the model and validation was comparable with performance in the training data. The internally validated scoring system classified patients roughly into quartiles of risk: low, low/medium, medium/high, and high, with 52% of patients categorized as medium/high to high risk, which had corresponding 1-year mortality rates of 11% and 23%, respectively. Aneurysm diameter was below Society for Vascular Surgery recommended treatment thresholds, less than 5.0 cm in females, less than 5.5 cm in males, in 17% of patients, and equals 679,3961, 41% of whom were categorized as medium/high or high risk. This subgroup had significantly increased in hospital complication rates, 18% versus 12%, p equals 0.02, and 1-year mortality, 13% versus 5%, p less than 0.0001, compared with patients in the low/medium risk groups with guideline-compliant aneurysm diameters greater than or equal to 5.0 cm in females, greater than or equal to 5.5 cm in males. Conclusions. This validated preoperative prediction model for 1-year mortality after SAVR incorporates physiological, functional, and anatomical variables. This novel and simplified scoring system can effectively discriminate mortality risk and, when applied prospectively, may facilitate improved preoperative decision-making, complex aneurysm care delivery, and resource allocation. Descending thoracic aortic mural ulceration is associated with postoperative spinal cord ischemia after branched endovascular aortic aneurysm repair. Objective. Paraplegia is one of the most feared complications after thoracoabdominal aortic aneurysm repair. The purpose of this study is to determine whether aortic thrombus characteristics are associated with spinal cord ischemia, SCI, after branched endovascular aneurysm repair, BEVR. Methods. From April 2011 to April 2020, 62 patients underwent elective BEVR for thoracoabdominal aortic aneurysm and pararenal aortic aneurysms using a low-profile device and had a complete preoperative computed tomography angiography of the aorta from the sinotubular junction to the aortic bifurcation. Aortic thrombus was evaluated for thrombus thickness greater than or equal to 5 mm, thrombus greater than 2/3 of aortic circumference, and the presence of an ulcer-like thrombus. 1 point was assigned at each 5 mm axial image if all 3 criteria were met, resulting in a total Shaggy score for the entire aorta. Data on demographics, procedural details, and outcomes were collected prospectively. All patients underwent a standard spinal cord protection protocol, including routine cerebrospinal fluid drainage. In July 2016, an insulin infusion protocol, IIP, was initiated to maintain postoperative blood glucose levels less than 120 mg/dl for 48 hours. The primary clinical endpoint was postoperative SCI. Results. 16% patients developed postoperative SCI, 6 with transient periparesis, 2 with persistent periparesis, and 2 with persistent paraplegia. Patients with SCI were older, had higher Shaggy scores, and were less likely to have been on an UP. There were no significant differences in demographics, aneurysm type, or operative parameters. In a logistic multivariate regression model for SCI, age, odds ratio, or 1.2, 1.1 to 1.4, p equals 0.02, and Shaggy score, or 1.2, 1.1 to 1.4, p equals 0.02, were independently associated with increased risk of SCI, whereas treatment with the UP was associated with lower risk of SCI, or 0.04, 0.006 to 0.50, p equals 0.05. Of the individual components of the Shaggy score, higher descending thoracic aortic ulcer scores were the most strongly associated with postoperative SCI, p equals 0.009. Conclusions. Preoperative characterization of aortic wall thrombus is an important adjunctive tool for individualized clinical decision-making and patient counseling about the risk of SCI after BEVR. Access site complications in thoracic endovascular aortic repair. Background. Percutaneous access and use of vascular closure devices facilitate thoracic endovascular aortic repair (TAVR) procedures during local anesthesia and allow immediate detection of signs of spinal ischemia. However, the very large bore access, usually greater than or equal to 22 sheath, associated with TAVR increases the risk of vascular complications. In this study, we sought to define the safety and feasibility of 2 percutaneous femoral artery closure devices during TAVR in terms of access site vascular complications and major, life-threatening, or fatal bleeding, greater than or equal to major, within 48 hours. Access site vascular complications were defined as technical failure of vascular closure or later formation of pseudoaneurysm. Methods. From March 2010 to December 2022, 199 transfemoral TAVR were performed at Helsinki University Central Hospital, Finland. We retrospectively categorized these into 3 groups, based on surgeon preference for the access technique and femoral artery closure method: 1. Surgical cutdown and vessel closure, N equals 85, 42.7%. 2. Percutaneous access and vascular closure with suture-based ProGlide, N equals 56, 28.1%, or 3. Percutaneous access and vascular closure with ultrasound-guided plug-based MANTA, N equals 58, 29.1%. The primary outcome measure was technical success of vascular closure and access site vascular complications during index hospitalization. Secondary outcome measures were greater than or equal to major bleeding, early mortality, and hospital stay. Results. The technical success rate was 97.6% versus 91.1% versus 93.1% for surgical cutdown, ProGlide, and MANTA, respectively, p equals 0.213. The rate of access site vascular complication was 3.5% versus 8.9% versus 10.3%, respectively, p equals 0.290, with 2 pseudoaneurysms detected postoperatively and conservatively managed in the MANTA group. The vascular closure method was not associated with increased risk of greater than or equal to major bleeding, early mortality, or hospital stay on univariate analysis. Predictors for greater than or equal to major bleeding after TAVR in multivariable analysis were urgent procedure, odds ratio, 2.8, 95% confidence interval, 1.4 to 5.5, p equals 0.003, and simultaneous aortic branch revascularization, odds ratio, 2.7, 95% confidence interval, 1.3 to 5.4, p equals 0.008. Conclusions. In this study, the technical success rates of the percutaneous techniques demonstrated their feasibility during TAVR. However, the number of access site complications for percutaneous techniques was higher compared with open approach, although the difference was not statistically significant. In the lack of evidence, the safety of the new MANTA plug-based vascular closure for TAVR warrants further investigation. The Association of Ruptured Abdominal Aortic Aneurysm Diameter with Mortality in the International Consortium of Vascular Registries. Background. The mortality after ruptured abdominal aortic aneurysm, RAA, repair is high, despite improvements in perioperative care, centralization of emergency vascular surgical services, and the introduction of endovascular aneurysm repair, EVAR. The diameter of intact AAA has been shown to be a predictor of short and long-term survival. The aim of this study was to analyze the impact of AAA diameter on mortality for RAA repair using contemporary data collected from the International Consortium of Vascular Registries and compare outcomes by sex and the type of repair patients received. Methods. Prospective registry data on repair of RAA from 7 countries were collected from 2010 to 2016. The primary outcome was perioperative mortality after EVAR and open surgical repair, OSR. Data were stratified by type of repair and sex. Logistic regression models were used to estimate odds ratio, or, for the association between AAA diameter and perioperative mortality and the association between type of repair and mortality. Multivariable logistic regression models were used to adjust for differences in patient characteristics. Results. The study population consisted of 6,428 patients with a mean age ranging from 70.2 to 75.4 years. The mean AAA diameter was 7.7 plus or minus 1.8 centimeters. Females had a significantly smaller AAA diameter at presentation compared with males, 6.9 plus or minus 1.6 centimeters versus 7.9 plus or minus 1.8 centimeters, p less than 0.001. Who underwent OSR had larger AAA diameters compared with those who underwent EVAR, p less than 0.001. Females who underwent repair were significantly older, p less than 0.001. Males were more likely to have cardiac disease, diabetes mellitus, and renal impairment. Overall, AAA diameter was a predictor of mortality in univariate and multivariate analysis. When analyzing EVAR and OSR separately, the impact of AAA diameter per centimeter increase on mortality was apparent in both males and females undergoing EVAR, but not OSR. EVAR, male or 1.09, 95% confidence interval, 1.03 to 1.16, and EVAR, female or 1.17, 95% confidence interval, 1.02 to 1.35. The early mortality rate for males and females who underwent EVAR was 18.9% and 25.9%, p less than 0.001, respectively. The corresponding mortality for males and females who underwent OSR was 30.2% and 38.6%, p less than 0.001, respectively. Conclusions. In these real-world international data, there is a significant association between RA diameters and early mortality in males and females. This association was more evident in patients undergoing EVAR, but not shown in OSR. Despite improvements in overall AAA repair outcomes, the risk of mortality after RA repair is consistently higher for females. Next article is from Surgical Endoscopy. Risk factors for the failure of endoscopic balloon dilation to manage anastomotic stricture from colorectal surgery, retrospective cohort study. Background. An anastomotic stricture after colorectal surgery is principally managed by endoscopic balloon dilation, EBD. Although this intervention is effective, however, subsequent procedures or surgical interventions are often required. This study aimed to assess the long-term outcomes of EBD for anastomotic stricture arising from colorectal cancer surgery. Materials and methods. We analyzed 173 patients who received curative surgery for colorectal cancer at our hospital between January 2000 and December 2022, and had undergone EBD to manage anastomotic stricture. The medical records of these cases were retrospectively reviewed to assess the outcomes and risk factors for restenosis and permanent stoma. Results. Of the 173 study patients, 41, 23.7%, presented with restenosis with a median time to recurrence of 49, 37 to 150 days. The restenosis group was significantly younger, 55.6 years versus 60.8 years, with a more prominent rectal location, 80.5% versus 57.6%, a higher incidence of hand-sewn anastomosis, 24.4% versus 5.3%, and a higher percentage of neoadjuvant radiotherapy, 34.1% versus 5.3%, p less than 0.001. Multivariable analysis indicated neoadjuvant radiotherapy, adjusted HR 2.48, 95% C 1.03 to 5.95, and cerebral vascular disease, adjusted HR 6.97, 95% C 2.15 to 22.54, as independent prognostic factors for restenosis. 14 patients, 8.1%, required a permanent stoma due to treatment failure. All cases needing a permanent stoma were male, 14 patients, 100%, p equals 0.007, and this group had a higher rate of neoadjuvant radiotherapy, adjuvant chemotherapy, and hand-sewn anastomosis. Conclusion. Patients receiving neoadjuvant radiotherapy are most prone to restenosis after an EBD intervention to manage an anastomotic stricture. Neoadjuvant radiotherapy is also a strong risk factor for requiring a permanent stomas due to treatment failure. Robot-assisted radical resection of colorectal cancer using the Kang Duo surgical robot versus the Da Vinci Xi robotic system, short-term outcomes of a multicenter randomized controlled non-inferiority trial. Background. The Kang Duo surgical robot, KDSR-01, was recently developed in China. This study aims to evaluate the short-term outcomes of KDSR-01 for colorectal cancer surgery. Methods. This is a multicenter randomized controlled non-inferiority trial conducted in 3 centers in China. Enrolled patients were randomly assigned at a 1-to-1 ratio to receive surgery using the KDSR-01 system, KD group, or the Da Vinci Xi, DV, robotic system, DV group. The primary endpoint was the success rate of operation. The second endpoints were surgical outcomes, pathological outcomes, and postoperative outcomes. Results. Between July 2022 and May 2023, a total of 100 patients were included in the trial and randomly assigned to the KD group, 50 patients, and the DV group, 50 patients. All cases were completed successfully without conversion to laparoscopic surgery. The time to flatus and the incidence of postoperative complications of Clavin-Dindo grade 2 or higher grade were comparable between the two groups. Surgeons reported a high level of comfort with the KDSR-01 system. In the subgroup analysis of different operative procedures, there were no significant differences in docking time, consult time, blood loss, and the length of the incision for extraction between the two groups. There were no differences in pathological outcomes, including maximum tumor diameter, circumferential resection margin, distal resection margin, and number of harvested lymph nodes. Conclusions. The KDSR-01 system was a viable option for colorectal cancer robotic surgery, with acceptable short-term outcomes comparable to the Da Vinci's eye robotic system. Next article is from Annals of Surgical Oncology. Neoadjuvant chemotherapy is associated with increased risk of postoperative DVT after distal pancreatectomy for pancreatic adenocarcinoma, UNSCOP analysis. Background. Venous thromboembolism, VTE, remains a persistent source of postoperative morbidity despite prevention and mitigation efforts. Cancer, surgery, and chemotherapy are known risk factors for VTE. Existing literature suggests that neoadjuvant therapy, NAT, may contribute to increased VTE risk in the postoperative period, but few authors specifically examine this relationship in distal pancreatic adenocarcinoma, PDAC. In this study, we analyzed the association of NAT and postoperative VTE in patients who underwent distal pancreatectomy, DP, for PTAC. Patients and methods. Using the American College of Surgeons, ACS, National Surgical Quality Improvement Program, SCUP, database, we analyzed the procedure-targeted files for pancreatectomy from 2014 to 2020. Adults with PTAC who underwent DP were grouped by receipt of NAT. The primary outcome was the rate of deep venous thrombosis, DVT, and the secondary outcome was the rate of pulmonary embolism, PE. We performed univariate and multivariate logistic regression analysis to determine risk factors associated with postoperative DVT. Results. There were 4,327 patients with PTAC who underwent DP. Of these, 1,414, 32.7%, had NAT. Receipt of NAT was significantly associated with postoperative DVT requiring therapy, 3.5% versus 2.3%, P equals 0.02, but was not associated with PE, P equals 0.42. On MVA, NAT was associated with a 73% greater chance of developing postoperative DVT, odds ratio, or 1.73, 95% C 1.18 to 2.55. Conclusions. Patients who receive NAT prior to DP for PTAC are 73% more likely to develop postoperative DVT compared with upfront resection. As NAT becomes more commonplace, these high-risk patients should be prioritized for guideline-recommended extended duration prophylaxis. Accuracy and prognostic impact of nodal status on preoperative imaging for management of pancreatic neuroendocrine tumors, a multi-institutional study. Background. We sought to define the accuracy of preoperative imaging to detect lymph node metastasis, LNM, among patients with pancreatic neuroendocrine tumors, PNITs, as well as characterize the impact of preoperative imaging nodal status on survival. Methods. Patients who underwent curative intent resection for PNITs between 2000 and 2020 were identified from 8 centers. Sensitivity and specificity of computed tomography, CT, magnetic resonance imaging, MRI, positron emission tomography, PET-CT, and octreoscan for LNM were evaluated. The impact of preoperative lymph node status on lymphadenectomy, LND, as well as overall and recurrence-free survival was defined. Results. Among 852 patients, 235, 27.6%, individuals had LNM on final histologic examination, HN1. The sensitivity, specificity, positive predictive value, PPV, and negative predictive value, NPV, were 12.4%, 98.1%, 71.8%, and 74.4% for CT, 6.3%, 100%, 100%, and 80.1% for MRI, 9.5%, 100%, 100%, and 58.7% for PET, 11.3%, 97.5%, 66.7%, and 70.8% for octreoscan, respectively. Among patients with any combination of these imaging modalities, overall sensitivity, specificity, PPV and NPV was 14.9%, 97.9%, 72.9%, and 75.1%, respectively. Preoperative N1 on imaging, IN1, was associated with a higher number of LND, IN1 13 versus IN0 9, p equals 0.003, and a higher frequency of final HN1 versus preoperative IN0, IN1 72.9% versus IN0 24.9%, p less than 0.001. Preoperative IN1 was associated with a higher risk of recurrence versus preoperative IN0, median recurrence-free survival, IN1 HN1 47.5 versus IN0 HN1 92.7 months, p equals 0.05. Conclusions. Only 4% of patients with LNM on final pathologic exam had preoperative imaging that was suspicious for LNM. Traditional imaging modalities had low sensitivity to determine nodal status among patients with PNITs. Laparoscopic dissection of lymph node station 16, why and how? Background. Dissection of para-aortic lymph nodes, station 16, provides an important prognosticator for patients with gastrointestinal, colorectal, and hepatobiliary cancers. 1, 2, 3, 4. For example, a positive station 16 lymph node has been shown to lead to 2-year survival of 3% in patients with pancreas adenocarcinoma, akin to stage 4 disease. 5, 6. Thereby, station 16 involvement can help with the risk/benefit stratification of the decision to move forward with radical surgery. 7, 8, 9. Furthermore, it has been shown for gallbladder cancer that involvement of station 16 cannot necessarily be predicted from the dissection of the hepatoduodenal ligament lymph nodes only. 10, 11. Technique. With the patient in the French position, a complete cauterization and a cattle broche maneuver is performed, allowing for visualization of lane station 16B. Station 16B is the inferior border of the station 16 compartment. The left renal vein, LRV, serves as an important landmark to identify the superior border of the dissection comprised by stations 16A2 and 16B1. Station 16A2 dissection may be associated with a traction injury of the left renal vein or damage of right renal or suprarenal arteries, and is dissected if there are specific concerns regarding involvement. Conclusions. While station 16 provides important prognostic information for risk stratification, a strategic and stepwise approach is needed for a safe sampling. This is accomplished by wide mobilization of the duodenum, implementation of thermal fusion to minimize chyle leak, and careful dissection below the left renal vein. Benchmarks in liver resection for intrahepatic cholangiocarcinoma. Introduction. Benchmarking in surgery has been proposed as a means to compare results across institutions to establish best practices. We sought to define benchmark values for hepatectomy for intrahepatic cholangiocarcinoma, ICC, across an international population. Methods. Patients who underwent liver resection for ICC between 1990 and 2020 were identified from an international database, including 14 Eastern and Western institutions. Patients operated on at high-volume centers who had no preoperative jaundice, ASA class less than 3, body mass index less than 35 km/m2, without need for bile duct or vascular resection were chosen as the benchmark group. Results. Among 1,193 patients who underwent curative intent hepatectomy for ICC, 600, 50.3%, were included in the benchmark group. Among benchmark patients, median age was 58.0 years, interquartile range, IQR, 49.0 to 67.0, only 28, 4.7%, patients received neoadjuvant therapy, and most patients had a minor resection, N equals 499, 83.2%. Benchmark values included greater than or equal to 3 lymph nodes retrieved when lymphadenectomy was performed, blood loss less than or equal to 600 milliliters, perioperative blood transfusion rate less than or equal to 42.9%, and operative time less than or equal to 339 minutes. The postoperative benchmark values included 2 achievement greater than or equal to 59. 3%, positive resection margin less than or equal to 27.5%, 30-day readmission less than or equal to 3.6%, Clavin-Dindo 3 or more complications less than or equal to 14.3%, and 90-day mortality less than or equal to 4.8%, as well as hospital stay less than or equal to 14 days. Conclusions. Benchmark cutoffs targeting short-term perioperative outcomes can help to facilitate comparisons across hospitals performing liver resection for ICC, assess interinstitutional variation, and identify the highest performing centers to improve surgical and oncologic outcomes. Next article is from International Journal of Surgery. Trends and Benefits of Early Hip Arthroplasty for Femoral Neck Fracture in China, a national cohort study. Background. Limited studies have examined the benefits of early arthroplasty within 48 hours from admission to surgery for femoral neck fractures, FNFs. Using the National Inpatient Database, the authors aim to investigate the trends in early arthroplasty within 48 hours for FNFs in China and to assess its effect on in-hospital complications and 30-day readmission patterns. Materials and methods. This was a retrospective cohort study. Patients receiving primary total hip arthroplasty (THA) or hemiarthroplasty (HA) for FNFs in the hospital quality monitoring system between 2013 and 2019 were included. After adjusting for potential confounders with propensity score matching, a logistic regression model was performed to compare the differences in in-hospital complications, i.e. in-hospital death, pulmonary embolism, deep vein thrombosis, DVT, wound infection, and blood transfusion, rates and causes of 30-day readmission between early and delayed arthroplasty. Results. During the study period, the rate of early THA increased from 18.0 to 19.9%, and the rate of early HA increased from 14.7 to 18.4%, p less than 0.001. After matching, 11,731 pairs receiving THA and 13,568 pairs receiving HA were included. Compared with delayed THA, early THA was associated with a lower risk of pulmonary embolism, odds ratio, or 0.51, 95% C, 0.30 to 0.88, DVT, or 0.59, 95% C, 0.50 to 0.70, blood transfusion, or 0.62, 95% C, 0.55 to 0.70, 30-day readmission, or 0.82, 95% C, 0.70 to 0.95, and venous thromboembolism-related readmission, or 0.50, 95% C, 0.34 to 0.74. Similarly, early HA was associated with a lower risk of DVT, or 0.70, 95% C, 0.61 to 0.80, and blood transfusion, or 0.74, 95% C, 0.68 to 0.81, than delayed HA. Conclusion. Despite a slight increase, the rate of early arthroplasty remained at a low level in China. Given that early arthroplasty can significantly improve prognosis, more efforts are needed to optimize the procedure and shorten the time to surgery. Low back pain-driven inpatient stays in the United States, a nationwide repeated cross-sectional analysis. Background. Low back pain, LBP-driven inpatient stays are resource-intensive and costly, yet data on contemporary national trends are limited. Materials and methods. This study used repeated cross-sectional analyses through a nationally representative sample, U.S. National Inpatient Sample, 2016 to 2019. Outcomes included the rate of LBP-driven inpatient stays, the resource utilization, the proportion of receiving surgical treatments and hospital costs, and prognosis, hospital length of stay, and the proportion of non-routine discharge among LBP-driven inpatient stays. LBP was classified as overall, nonspecific, and specific, i.e. cancer, cauda equina syndrome, vertebral infection, vertebral compression fracture, axial spondyloarthritis, radicular pain, and spinal canal stenosis. Analyses were further stratified by age, sex, and race/ethnicity. Results. 292,987 LBP-driven inpatient stays, weighted number, 1,464,690, were included, with 269,080, 91.8%, of these for specific LBP and 23,907, 8.2%, for nonspecific LBP. The rate of LBP-driven inpatient stays varied a lot across demographic groups and LBP subtypes, for example for overall LBP, highest for non-Hispanic white 180.4 versus lowest for non-Hispanic Asian/Pacific Islander 42.0 per 100,000 population. Between 2016 and 2019, the rate of nonspecific LBP-driven inpatient stays significantly decreased, relative change, 46.9%. However, substantial variations were found within subcategories of specific LBP. Significant increases were found for vertebral infection, relative change, 17.2%, vertebral compression fracture, relative change, 13.4%, and spinal canal stenosis, relative change, 19.9%, while a significant decrease was found for radicular pain, relative change, 12.6%. The proportion of receiving surgical treatments also varied a lot, for example for overall LBP, highest for non-Hispanic white 74.4% versus lowest for non-Hispanic Asian/Pacific Islander 62.8%, and significantly decreased between 2016 and 2019, for example for nonspecific LBP, relative change, 28.6%. Variations were also observed for other outcomes. Conclusions. In the U.S., the burden of LBP-driven inpatient stays, i.e. rates of LBP-driven inpatient stays, resource utilization, and prognosis among LBP-driven inpatient stays, is enormous. More research is needed to understand why the burden varies considerably according to the LBP subtype, i.e. nonspecific and specific LBP, as well as subcategories of specific LBP, and the subpopulation concerned, i.e. stratified by age, sex, and race/ethnicity. Characterization changes and research waste in randomized controlled trials of global bariatric surgery over the past 20 years, cross-sectional study. Background. The results of several large randomized controlled trials, RCTs, have changed the clinical practice of bariatric surgery. However, the characteristics of global RCTs of bariatric surgery have not been reported internationally, and whether there was research waste in these RCTs is unknown. Methods. Search clinicaltrials.gov for bariatric surgery RCTs registered between January 2000 and December 2022 with the keywords Roux-en-Y gastric bypass and sleeve gastrectomy. The above analysis was conducted in January 2023. Results. A total of 326 RCTs were included in this study. The number of RCTs registered for sleeve gastrectomy and gastric bypass surgery increased year by year globally. Europe has always accounted for the largest proportion, Asia has gradually increased, and North America has decreased. A total of 171 RCTs were included in the analysis of waste, of which 74, 43.8%, were published. Of the 74 published RCTs, 37, 74, 50.0%, were judged to be adequately reported, and 36, 74, 48.6%, were judged to have avoidable design defects. In the end, 143 RCTs, 171, 83.6%, had at least one research waste. Body weight change as the primary endpoint, or 0.266, 95% C, 0.103 to 0.687, p equals 0.006, and enrollment greater than 100, or 0.349. 95% C, 0.146 to 0.832, p equals 0.018, were independent protective factors for research waste. Conclusions. This study for the first time describes the characteristic changes of the mainstream RCT of bariatric surgery globally in the last 20 years and identifies a high research waste burden and predictive factor in this area, which provides reference evidence for carrying out bariatric surgery RCTs more rationally. Insufficiency of plasmatic arginine/homoarginine during the initial postoperative phase among patients with tumors affecting the medulla oblongata heightens the likelihood of neurogenic pulmonary edema following surgery. Background: this prospective clinical study aims to investigate the fluctuations of neurotransmitters in peripheral venous blood during the perioperative period, and to identify independent predictors for postoperative neurogenic pulmonary edema, NPE, in patients with medulla oblongata-involved tumors. Materials and methods. Peripheral venous blood samples of the enrolled patients at 7 perioperative time points, as well as their medical records and radiologic data, were collected. High-performance liquid chromatography tandem mass spectrometry was utilized to detect the concentrations of 39 neurotransmitters in these samples. The study applied univariate and multivariate generalized estimating equation (GE) logistic regression analyses to explore independent predictors of postoperative NPE, and one-way repeated measures ANOVA to compare the concentrations of the same neurotransmitter at different perioperative time points. Results. The study included 36 patients with medulla oblongata-involved tumors from January to December 2019, and found that 13.9% of them experienced postoperative NPE. The absence of intraoperative use of sevoflurane, P equals 0.008, decreased concentrations of arginine, P equals 0.026, and homoarginine, P equals 0.030, and prolonged postoperative tracheal extubation, P less than 0.001, were identified as independent risk factors for postoperative NPE in medulla oblongata-involved tumor patients. Pairwise comparison analysis revealed that the perioperative decreases in arginine and homoarginine concentrations mainly occurred within the postoperative 8 hours. Conclusion. This study demonstrates that NPE is not uncommon in patients with medulla oblongata-involved tumors. The absence of intraoperative use of sevoflurane, decreased concentrations of plasmatic arginine and homoarginine, and prolonged postoperative tracheal extubation are independent predictors of postoperative NPE. These two neurotransmitters' concentrations drop mainly within the early postoperative hours and could serve as potential early warning indicators of postoperative NPE in clinical practice. Next article is from Journal of the American College of Surgeons. Impact of pre-hospital exsanguinating airway breathing circulation resuscitation sequence on patients with severe hemorrhage. Background. At the 2023 ATLS Symposium, the priority of circulation was emphasized through the X-airway breathing circulation, ABC, sequence, where X stands for exsanguinating hemorrhage control. With growing evidence from military and civilian studies supporting an X-ABC approach to trauma care, a pre-hospital advanced resuscitative care, ARC, bundle emphasizing early transfusion was developed in our Emergency Medical Services, EMS, system. We hypothesized that prioritization of pre-hospital X-ABC through ARC would reduce in-hospital mortality. Study design. This was a single-year prospective analysis of patients with severe hemorrhage. These patients were combined with our institution's historic controls before pre-hospital blood implementation. Included were patients with systolic blood pressure, SBP, less than 90 mm of mercury. Excluded were patients with penetrating head trauma or pre-hospital cardiac arrest. 2-to-1 propensity matching for X-ABC to ABC groups was conducted, and the primary outcome, in-hospital mortality, was compared between groups. Results. A total of 93 patients, X-ABC equals 62, ABC equals 31, met the inclusion criteria. There was no difference in patient age, sex, initial SBP, initial Glasgow Coma score, and initial shock index between groups. When compared with the ABC group, X-ABC patients had significant improvement in vitals at emergency department admission. Overall mortality was lower in the X-ABC group, 13% versus 47%, p less than 0.001. Multivariable regression revealed that pre-hospital circulation first prioritization was independently associated with decreased in-hospital mortality, odds ratio 0.15, 95% C 0.04 to 0.54, p equals 0.004. Conclusions. This is the first analysis to demonstrate a pre-hospital survival benefit of XABC in this subset of patient with severe injury and hemorrhagic shock. Standardization of pre-hospital XABC management in this patient population warrants special consideration. Validity of entrustable professional activities in a national sample of general surgery residency programs. Background: the American Board of Surgery has endorsed competency-based education as vital to the assessment of surgical training. From 2018 to 2020, a national pilot study was conducted at 28 general surgery programs to evaluate feasibility of implementing entrustable professional activities, EPAs, for 5 common general surgical conditions. Core competency milestones were also rated for each resident by program clinical competency committees. This study aimed to evaluate the validity of general surgery EPAs compared with milestones. Study design: prospectively collected, the identified EPA pilot study data were analyzed. EPAs studied were EPA 1, gallbladder, EPA 2, inguinal hernia, EPA 3, right lower quadrant pain, EPA 4, trauma, and EPA 5, consult. Variables abstracted included levels of EPA entrustment, 1 to 5, and corresponding milestone subcompetency ratings, 1 to 5, for the same study cycle. Spearman's correlations were used to evaluate the relationship between summative EPA scores and corresponding milestone ratings. Results: a total of 493 unique residents received a summative entrustment decision. EPA summative entrustment scores had moderate to strong positive correlation with mapped milestone subcompetencies, with median row value of 0.703. Among operation-focused EPAs, median row values were similar between EPA 1, 0.688, and EPA 2, 0.661, but higher for EPA 3, 0.833. EPA 4 showed a strong positive correlation with diagnosis and communication competencies, 0.724, whereas EPA 5, mapped to the most milestone subcompetencies, had the lowest median row value, 0.455. Conclusions: moderate to strong positive correlation was noted between EPAs and patient care, medical knowledge, and communication milestones. These findings support the validity of EPAs in general surgery and suggest that EPA assessments can be used to inform milestone ratings by clinical competency committees. International expert consensus on defining textbook oncologic outcomes in cytoreductive surgery and hyperthermic intraperitoneal chemotherapy for colorectal peritoneal metastasis. Background: textbook oncologic outcome, TOO, is a composite metric shown to correlate with improved survival after curative intent oncologic procedures. Despite increasing use among disciplines in surgical oncology, no consensus exists for its definition in cytoreductive surgery, CRS, and hyperthermic intraperitoneal chemotherapy, HIPEC. Study design: an international consensus-based study employed a Delphi methodology to achieve agreement. 54 senior surgeons from the peritoneal surface malignancies field received a questionnaire comprising 2 parameters divided into 3 surgical domains: operative, short-term, and long-term postoperative outcomes. 2 online meetings with participants defined the new criteria. Consensus was achieved when 75% of agreement rate was reached. Clinical data of patients who underwent CRS and HIPEC for colorectal peritoneal metastasis between 2010 and 2022 from one designated center, Sheba Medical Center, were collected, the consensus definition applied, and outcomes analyzed. Results: 38 surgeons, 70%, participated. Expert consensus 2 parameters for colorectal peritoneal metastasis CRS and HIPEC included the absence of unplanned reoperations during 30 days post-operation, absence of severe postoperative complications, Clavin-Dindo greater than or equal to 3, absence of unplanned readmissions during 30 days post-operation, 90-day postoperative mortality, and absence of contraindications for chemotherapy within 12 weeks from operation, and included the achievement of complete cytoreduction, CC0. The study cohort consisted of 251 patients, and 151, 60%, met 2 criteria. Patients who achieved 2 had significantly better overall survival, median 67.5 months, 95% C, versus patients who did not achieve 2, median 44.6 months, 95% C, p less than 0.001, and significantly improved disease-free survival, median 12 months, 95% C, versus 9 months, 95% C, p equals 0.01. Conclusions. Achievement of 2 is defined by consensus statement is associated with improved survival. Clinical and histological response to talimogene laherpareptic therapy in advanced melanoma, impact on overall survival. Background. Talimogene laherpareptic, TVEC, is an FDA-approved oncolytic herpesvirus therapy used for unresectable stage 5 through 4 metastatic melanoma. However, the correlation between clinical complete response, CCR, and pathologic complete response, PCR, in patients treated with TVEC is understudied. Study design. We conducted a retrospective study from a prospectively maintained IRB-approved melanoma single-center database in patients treated with TVEC from October 2015 to April 2022. Patients were categorized into 3 groups: CCR with PCR, CCR without PCR, and less than CCR. The primary endpoint was overall survival. We used descriptive statistics, chi-square tests, and Wilcoxon rank-sum tests to compare key covariates among exposure groups. We used survival analysis to compare survival curves, and reported hazard ratio of death, 95% C, across exposure groups. Results. We included 116 patients with a median overall survival, interquartile range, of 22.7, 14.8 to 39.3 months. The majority were men, 69%, and white, 97.4%, with a median age of 74.5 years. More than half of patients, N equals 60, 51.6%, achieved CCR. Distribution among the groups was as follows: CCR with PCR, 35.3%, CCR without PCR, 16.3%, and less than CCR, 48.4%. Median overall survival time, interquartile range, was 26.5, 18.6 to 36.0 months for CCR with PCR, 22.7, 14.4 to 35.5 months for CCR without PCR, and 17.8, 9.2 to 47.0 months for less than CCR. Log rank p-value equals 0.0033. Conclusions. Patients achieving CCR with PCR after TVEC therapy have the most favorable overall survival outcomes, whereas those achieving CCR without PCR have inferior survival and those achieving less than CCR have the poorest overall survival outcomes. These findings emphasize the importance of histological confirmation and provide insights for optimizing TVEC therapy in patients with advanced melanoma. Use of preoperative endoscopic capsule-based pH testing before bariatric surgery. Background. Vertical sleeve gastrectomy is the most performed bariatric operation in the U.S., however, a significant number of patients suffer from persistent or new-onset reflux. No consensus for objective preoperative evaluation in these patients exists. We compared capsule-based pH testing versus GERD symptom scoring to determine extent of preoperative GERD to aid in procedure selection for bariatric surgery. Study design. An IRB-approved retrospective review of consecutive patients at a single institution was performed from April 2021 to December 2022. During initial consultation for bariatric surgery, a validated GERD symptom subjective survey was administered. All patients demonstrating interest in sleeve gastrectomy or had a history of reflux underwent upper endoscopy with capsule-based pH testing. Results. 62 patients underwent preoperative endoscopy with capsule-based pH testing and completed GERD symptom assessment surveys. Median BMI was 43.4 kg/m2 and 66.1% of patients were not taking a proton pump inhibitor before performance of pH testing. There was negligible linear association between the objective Demister score obtained by capsule-based pH probe and GERD symptom survey scores. Median GERD symptom survey scores did not differ between patients with and without a diagnosis of GERD based on pH testing, all p-values greater than 0.11. Conclusions. An objective method for identifying severe GERD in the preoperative assessment may aid in the decision tree for procedure selection and informed consent process. Patients with significant preoperative GERD may be at higher risk for future GERD-related sleeve complications. Capsule-based pH testing may prove to be superior to subjective symptom scoring systems in this patient population. Update on outcomes of a novel pathway for thoracic surgery training. Background. The Joint Surgery Thoracic Surgery (JSTS) pathway began as a pilot program to grant both general surgery (GS) residency and thoracic surgery (TS) fellowship credit for 12 months of the PGY 4 and 5 years. This review updates the outcomes of this novel program. Study design. GS and TS programs in all approved JSTS institutions were contacted for data collection, including JSTS enrollee demographics and GS and TS case logs, CLs. National GS and TS CL data, and program and institutional data were publicly available. Enrollee case numbers were compared with those of their contemporaries. The American Board of Surgery and American Board of Thoracic Surgery provided certification data. Only enrollees who completed GS through 2019 were included. Results. There were 90 JSTS enrollees in 14 institutions. 2 enrollees withdrew and 1 had not completed TS at the time of data collection, leaving 87 for analysis. GCLs were available for all 87 enrollees. TSCLs were available for all 62 enrollees who completed fellowship in 2016 or later. In GS, enrollees recorded fewer cases than their contemporary PGY-5s nationally in all domains except thoracic and endocrine. In TS, mean enrollee case numbers exceeded those of national contemporaries in every major category. 62 JSTS enrollees have achieved American Board of Surgery certification. 82 enrollees are American Board of Thoracic Surgery certified, with 5 currently in the certification process. Conclusions. The JSTS pathway has proven a successful alternative route for TS training and could be a blueprint for other specialties considering novel avenues to specialty training. Health inequity in likelihood and time to renal recovery after living kidney donation, implications for kidney health in Black Americans. Background. Live donor kidney transplantation has been popularized to help mitigate the organ shortage crisis. At the time of living donor nephrectomy, living donors lose 50% of their kidney function or glomerular filtration rate, GFR. Studies have shown that in healthy living donors, the remaining kidney is able to adapt and recover 10% to 25% of post-donation lost GFR. GFR recovery is critical to long-term kidney health, particularly for Black Americans who disproportionately suffer from kidney disease with an incidence 2.5 times white Americans. To date, no study has examined whether health inequities in renal recovery post-donation exist. Study design. We retrospectively analyzed 100,121 living kidney donors reported to the Scientific Registry of Transplant Recipients between 1999 and 2021. We estimated GFR, EGFR, using the Chronic Kidney Disease Epidemiology Collaboration 2021 equation and predicted the likelihood, logistic regression, and time, Cox regression, to recovery of 60% and 75% pre-donation EGFR. Models adjusted for age, sex, race, BMI, and pre-donation EGFR. Results. Black patients were 47%, adjusted odds ratio 0.53, 95% C 0.50 to 0.56, P less than 0.001, and 43%, adjusted odds ratio 0.57, 95% C 0.54 to 0.60, P less than 0.001, less likely to recover 60% and 75% of pre-donation EGFR, respectively, compared with their white counterparts. The hazard ratio for time to renal recovery of 60% and 75% of pre-donation EGFR was 22%, adjusted hazard ratio 0.78, 95% C 0.76 to 0.80, P less than 0.001, and 38%, adjusted hazard ratio 0.62, 95% C0.60 to 0.65, P less than 0.001 lower, respectively, than white patients. Conclusions. Black living kidney donors were less likely to recover predonation EGFR, and time to renal recovery was significantly longer than their white counterparts. These data highlight the need for enhanced living kidney donor follow-up, particularly for Black living kidney donors who are at greatest future risk of end-stage kidney disease. Social Vulnerability Index and Survivorship after Colorectal Cancer Resection. Background. Race and socioeconomic status incompletely identify patients with colorectal cancer, CRC, at the highest risk for screening, treatment, and mortality disparities. Social Vulnerability Index, SVI, was designed to delineate neighborhoods requiring greater support after external health stressors, summarizing socioeconomic, household, and transportation barriers by census tract. SVI is implicated in lower cancer center use and increased complications after colectomy, but its influence on long-term prognosis is unknown. Herein, we characterized relationships between SVI and CRC survival. Study design. Patients undergoing resection of stage I to IV CRC from January 2010 to May 2023 within an academic health system were identified. Clinicopathologic characteristics were abstracted using Institutional National Cancer Database (NSCUP). Addresses from electronic health records were geocoded to SVI. Overall survival and cancer-specific survival were compared using Kaplan-Meier and Cox proportional hazards methods. Results. A total of 872 patients were identified, comprising 573, 66%, patients with colon tumor and 299, 34%, with rectal tumor. Patients in the top SVI quartile, 32%, were more likely to be Black, 41% versus 13%, P less than 0.001, carry less private insurance, 39% versus 48%, P equals 0.02, and experience greater comorbidity. American Society of Anesthesiologists Physical Status 3, 86% versus 71%, P less than 0.001, without significant differences by acuity, stage, or CRC therapy. In multivariable analysis, high SVI remained associated with higher all-cause, hazard ratio 1.48, 95% C 1.12 to 1.96, P less than 0.01, and cancer-specific survival mortality, hazard ratio 1.71, 95% C 1.10 to 2.67, P equals 0.02. Conclusions. High SVI was independently associated with poorer prognosis after CRC resection beyond the perioperative period. Acknowledging needs for multi-institutional evaluation and elaborating causal mechanisms, neighborhood-level vulnerability may inform targeted outreach in CRC care. Incidental but not insignificant, thyroid cancer in patients with Graves' disease. Background. Graves' disease is the most common cause of hyperthyroidism in the U.S. Treatment with antithyroid drugs and radioactive iodine is more commonly used than surgical management with total thyroidectomy, TTX. However, incidentally discovered thyroid cancer, TC, has been described on surgical pathology from patients who underwent surgical treatment of Graves' disease, which would be missed with these other treatment strategies. We sought to determine the incidence rate of TC among patients with surgically treated Graves' disease. Study design. We retrospectively reviewed patients with Graves' disease who underwent TTX at a single institution from 2011 to 2023. Pathology reports were reviewed for TC. Patient demographics, preoperative laboratory and radiological evaluations, preoperative medical management, and surgical outcomes were compared between patients with and without incidental TC. Results. There were 934 patients, of whom 6.4%, patients had incidentally discovered TC on pathology. The majority, 58.3%, of patients had papillary thyroid carcinoma, followed by 33.3% with papillary microcarcinoma. Preoperative ultrasound, US, was obtained in 564, 60.4%, of patients, with 44.3% with nodules, but only 34, 13.7%, of those with nodules had TC on final pathology. Preoperative fine needle aspiration was obtained in 15 patients with TC, and 8 patients, 53.3%, were reported as benign lesions, which ultimately had TC on final pathology. There was no difference in sex, race or ethnicity, preoperative medical management, and postoperative outcomes between the two groups. Conclusions. Incidental TC was found on surgical pathology in 6.4% of patients undergoing TTX for Graves' disease. Preoperative imaging with US and fine needle aspiration were often unreliable at predicting TC. The incidence of TC should not be underestimated when counseling patients on definitive management for Graves' disease. Next article is from Journal of Trauma and Acute Care Surgery. Risk stratified thromboprophylaxis effects of aspirin versus low molecular weight heparin in orthopedic trauma patients, a secondary analysis of the PREVENT CLOT trial. Background. The PREVENT CLOT trial concluded that thromboprophylaxis with aspirin was non-inferior to low molecular weight heparin, LMWH, in preventing death after orthopedic trauma. However, it was unclear if these results applied to patients at highest risk of thrombosis. Therefore, we assessed if the effect of aspirin versus LMWH differed based on patients' baseline risk of venous thromboembolism (VTE). Methods. The PREVENT CLOT trial enrolled 12,211 adult patients with fractures. The secondary analysis stratified the study population into VTE risk quartiles, low, less than 1%, to high, greater than 10%, using the Caprini score. We assessed stratum-specific treatment effects using the win ratio method, in which each patient assigned to aspirin was paired with each assigned to LMWH. In each pair, we compared outcomes hierarchically, starting with death, then pulmonary embolism, deep vein thrombosis, and bleeding. The secondary outcome added patients' medication satisfaction as a fifth composite component. Results. In the high-risk quartile, N equals 3,052, 80% had femur fracture, pelvic or acetabular fractures. Thoracic, 47%, and head, 37%, injuries were also common. In the low-risk quartile, N equals 3,053, most patients had a tibia fracture, 67%, 5% had a thoracic injury, and less than 1% had head or spinal injuries. Among high-risk patients, thromboembolic events did not differ statistically between aspirin and LMWH win ratio, 0.94, 95% confidence interval, c. 0.82 to 1.08, p equals 0.42. This result was consistent in the low win ratio, 1.15, 95% c. 0.90 to 1.47, p equals 0.27, low medium win ratio, 1.05. 95% C, 0.85 to 1.29, p equals 0.68, and medium high-risk quartiles, win ratio, 0.94, 95% C, 0.80 to 1.11, p equals 0.48. When medication satisfaction was considered, favorable outcomes were 68% more likely with aspirin, win ratio, 1.68, 95% C, 1.60 to 1.77, p less than 0.001. Conclusion. Thromboembolic outcomes were similar with aspirin or LMWH, even among patients at highest risk of VTE. Aspirin was favored if medication satisfaction was also considered. Emergency vascular repairs and trauma, predictors of poor prognosis and a novel scoring system. Background. Vascular injuries comprise 1% to 4% of all trauma patients, and there are no widely used risk stratification tools. We sought to establish predictors of revascularization failures and compare outcomes of trauma and vascular surgeons. Methods. We performed a single institution, case control study of consecutive patients with traumatic arterial injuries who underwent open repair between 2016 and 2021. Multivariable logistic regression was used to investigate covariates impacting the primary composite outcome of repair failure/revision, amputation, or in-hospital mortality. Results. Among 165 patients, the median age was 34 years, 149, 90%, were male, and 99, 60%, suffered penetrating injury. Popliteal, 46%, and superficial femoral, 44%, arterial injuries were most common. Interposition graft/bypass was the most frequent repair, and equals 107, 65%. Revascularization failure was observed in 24 patients, 15%. Compared with trauma surgeons, vascular surgeons more frequently repaired blunt injuries, 66% versus 20%, p less than 0.001, anterior tibial, 18% versus 5%, p equals 0.012, or tibioperoneal injuries, 28% versus 4%, p less than 0.001, with a below-knee bypass, 38% versus 20%, p equals 0.019. Revascularization failure occurred in 10%, 9 of 93, of repairs by trauma surgeons and 21%, 13 of 61, of repairs by vascular surgeons. Mangled extremity severity score greater than 8, odds ratio, 15.6, 95% confidence interval, 4.4 to 55.9, p less than 0.001, and concomitant laparotomy or orthopedic procedure, odds ratio, 6.7, 95% confidence interval, 1.6 to 28.6, p equals 0.010, were independently associated with revascularization failure. A novel composite scoring system, UT Houston score, was developed by combining mangled extremity severity score, concomitant procedure, mechanism of injury, and injury location. This score demonstrated a sensitivity of 100% with a score of 0 and a specificity of 95% with a score of greater than 3. Conclusion. After traumatic arterial injury, trauma surgeons repaired less complex injuries but with fewer revascularization failures than vascular surgeons. The UT Houston score may be used to risk stratify patients to determine who may benefit from vascular surgery consultation. Association between blood pressure recording in pre-hospital setting and patient outcome in pediatric trauma patients, a propensity score matching study. Background. Rapid identification of the severity of injuries in the field is important to ensure appropriate hospital care for better outcomes. Vital signs are used as a field triage tool for critically ill or injured patients in pre-hospital settings. Several studies have shown that recording vital signs, especially blood pressure, in pediatric patients is sometimes omitted in pre-hospital settings compared with that in adults. However, little is known about the association between the lack of measurement of pre-hospital vital signs and patient outcomes. In this study, we examine the association between the rate of vital sign measurements in the field and patient outcomes in injured children. Methods. This study analyzed secondary data from the Japan Trauma Data Bank. We included pediatric patients, 0 to 17 years, with injuries who were transported by emergency medical services. Hospital survival was the primary outcome. We performed a propensity-matched analysis with nearest neighbor matching without replacement by adjusting for demographic and clinical variables to evaluate the effect of recording vital signs. Results. During the study period, 13,413 pediatric patients were included. There were 9,187 and 1,798 patients with and without pre-hospital blood pressure records, respectively. After matching, there were no differences in the patient characteristics or disease severity. Hospital mortality was significantly higher in the non-recorded group than in the recorded group, 4.3% versus 1.1%, p less than 0.001. The multiple logistic regression analysis results showed no pre-hospital record of blood pressure being associated with death, odds ratio, or 6.82, 95% confidence interval, c. 2.40 to 19.33. Glasgow Coma Scale score and injury severity score were also associated with death, or 0.71, 95% c. 0.63 to 0.81 and or 1.10, 95% c. 1.06 to 11.14, respectively. Conclusion. Pediatric patients without any blood pressure records in pre-hospital settings had higher mortality rates than those with pre-hospital blood pressure records. Feasibility and safety of intraoperative bile duct clearance by antegrade transcystic balloon sphincterplasty, a prospective observational pilot study. Background: concomitant cholecystolithiasis and cholecystolithiasis are common. Standard treatments are endoscopic retrograde cholangiography, ERC, followed by cholecystectomy or laparoendoscopic rendezvous. Endoscopic retrograde cholangiography has drawbacks, such as post-ERC pancreatitis or bleeding, and potentially more than one intervention is required to address common bile duct, CBD, stones. Safety and feasibility of an intraoperative antegrade transcystic single-stage approach during cholecystectomy with balloon sphincterplasty and pushing of stones to the duodenum has not been evaluated prospectively. The aim of this pilot study was to evaluate this procedure regarding safety, feasibility, and stone clearance rate. Methods: prospective single-center intervention study, super-reporting guideline. Main inclusion criterion was confirmed cholecystolithiasis, stones less than or equal to 6 mm, at intraoperative cholangiography. Success of the procedure was defined as CBD stone clearance at intraoperative control cholangiography, absence of symptoms and no elevated cholestasis parameters at 6 weeks follow-up. Simon's two-stage design was used to determine sample size. Results: from January 2021 to April 2022, a total of 57 patients fulfilled the final inclusion criteria and were included. Mild pancreatitis or cholangitis were present upon admission in 15, 26%, and 15, 26% patients, respectively. Median number of CBD stones was 1 to 6. Median stone diameter was 4 mm, 0.1 to 6 mm. Common bile duct stone clearance was achieved in 54 patients, 94%. The main reason for failed CBD clearance was the inability to push the guidewire along the biliary stone into the duodenum. Median intervention time was 28 minutes, 14 to 129 minutes. While there was no postoperative pancreatitis, 2 patients, 3.5%, had asymptomatic hyperlipemia 4 hours postoperatively. Conclusion: intraoperative CBD stone clearance by antegrade balloon sphincterplasty appears to be safe and highly feasible. Its overall superiority to the current standards warrants evaluation by a randomized controlled trial. Next article is from the American Journal of Surgery. Retracting the Thyroid Matters: Who Develops Asymptomatic Transient Thyrotoxicosis After Parathyroidectomy? Background: hyperthyroidism after parathyroidectomy is not a well-understood complication. We sought to determine the incidence and risk factors of hyperthyroidism after parathyroidectomy. Materials and methods. This is a prospective study of 91 patients undergoing parathyroidectomy. Pre- and postoperative thyroid-stimulating hormone TSH and free thyroxine T4 levels at 2-week follow-ups were collected. Bivariate analyses were conducted to compare demographics, laboratory results, and intraoperative findings between patients with normal and suppressed post-parathyroidectomy TSH. Results: 24.2% patients had suppressed TSH after parathyroidectomy and 2.2% reported symptoms of hyperthyroidism. All hyperthyroidism resolved within 6 weeks. No patients required medical treatment. Compared to the normal TSH group, the suppressed TSH group had significantly more bilateral explorations, 91.0% versus 58.0%, p equals 0.006, and superior parathyroid resections, 95.5% versus 65.2%, p equals 0.006. Conclusion: transient hyperthyroidism is common following parathyroidectomy, which is likely associated with intraoperative thyroid manipulation. Gentle retraction of thyroid glands in parathyroidectomy is warranted, especially during superior parathyroid gland resection. Epidural analgesia and postoperative ileus after incisional hernia repair with transversus abdominis release, results of a 5-year quality improvement initiative. Introduction. The optimal pain management strategy after open ventral hernia repair, VHR, with transversus abdominis release, TAR, is unknown. Opioids are known to have an inhibitory effect on the GI tract and cause postoperative ileus. Epidural analgesia is associated with lower postoperative ileus rates but may contribute to other postoperative complications. A propensity-matched retrospective review published by our group in 2018 found that epidural analgesia was associated with an increased length of stay and any postoperative complication after VHR. Epidural analgesia was therefore abandoned by our group following this publication. We aim to determine if discontinuation of epidural analgesia affected ileus rates after open VHR. Methods: patients who underwent open VHR with TAR from August 2014 to January 2022 at Cleveland Clinic Foundation with at least 30-day follow-up were retrospectively identified using the Abdominal Core Health Quality Collaborative Registry. Patients with and without epidural analgesia were compared. The primary outcome was postoperative ileus. Additional outcomes included length of stay, deep venous thrombosis, DVT, pneumonia, wound complications, and pain requiring intervention. Results: a total of 2,570 patients were included, 420 had an epidural, 2,150 did not. Preoperative patient and hernia characteristics were similar between both groups. Mean hernia width was 15.5 cm in the epidural group and 16.1 cm in the no epidural group. In the epidural group, ileus was seen in 9 of 420, 2.15%, of patients, which was significantly less than in the no epidural group, 400 of 2,150, 18.6%, p equals greater than 0.001. On multivariate analysis, epidurals were predictive of lower risk of ileus, or 0.04, 95% C 0.01 to 0.17, p equals 0.001, and pain requiring intervention, or 0.02, 95% C 0.00 to 0.71, p equals 0.02. Epidural analgesia was not associated with increased DVT rates, pneumonia, length of stay, SSI, or SAPI. Discussion: discontinuation of epidural analgesia was associated with a 9-fold increase in ileus rates after VHR with TAR. Epidurals may play an important role in limiting postoperative opioid use and therefore reducing risk of ileus. Other postoperative complications, including pneumonia and venous thrombosis, were not impacted by epidurals. Further prospective studies are needed to further define a ventral hernia patient population who will benefit from epidural analgesia. Protect the neck: devastating outcomes of cervical spine fractures in the elderly. Background: cervical spine fractures are associated with high mortality in elderly patients. This study aims to identify patient-related and in-hospital factors contributing to this mortality. Methods: a 3-year retrospective study of 235 patients aged 65 plus presenting with cervical spine fractures was performed. Age cohorts were 65 to 74, 75 to 84, and 85 plus years. Mortality was measured at 30, 90, 180, and 365 days post-discharge. Results: mortality was 11%, 15%, 19%, and 22% at 30, 90, 180, and 365 days respectively. Surgery and fracture pattern was not associated with mortality, p equals 0.37, p equals 0.28. Charlson Comorbidity Index, p less than 0.001, hazard ratio, HR, equals 1.3, functional dependency, p less than 0.001, HR equals 2.5, and delirium, p less than 0.001, HR equals 8.9, were associated with mortality between 0 and 365 days post-discharge. Conclusions: mortality in cervical spine fractures is associated with CCI and delirium, but not associated with operative management or fracture pattern. This suggests the need for careful consideration in patient selection for cervical spine procedures and aggressive inpatient delirium management. Negative workup? Laparoscopic cholecystectomy still alleviates symptoms. Background: studies have shown that patients with abdominal pain and biliary dyskinesia, low ejection fraction less than 35%, have significant improvement of symptoms following laparoscopic cholecystectomy, but there is lack of evidence that demonstrates whether patients with biliary symptoms and a normal ejection fraction, greater than 35%, will have similar results. Methods: Retrospective, single-center study of patients with biliary pain and negative workup, including HITA with F greater than 35%, who were treated with laparoscopic cholecystectomy from 2017 to 2022. Results: There were 117 total patients. The mean age was 45.49 plus or minus 15.5 years, and 101, 86%, were female. 101, 86%, of patients underwent a right upper quadrant ultrasound, 91 had normal findings, 9 difficult to visualize anatomy, and 1 had adenomyomatosis. All patients had a normal HITA scan and ejection fraction 104, 89%, of patients followed up in clinic within 30 days of surgical intervention. 87, 84%, reported resolution of preoperative symptomatology after surgical intervention. There was no statistically significant correlation between pain with CCK administration during HITA, p equals 0.803, scan or ejection fraction, p equals 0.0977, with resolution of symptoms. Conclusions: Laparoscopic cholecystectomy appears to be a beneficial intervention for patients with abdominal pain and normokinetic biliary disease. Offering surgical intervention early on can potentially save patients from exhaustive diagnostic investigations and possibly misdiagnosis. Next article is from World Journal of Surgery. Enhanced Recovery Protocols After Surgery, a systematic review and meta-analysis of randomized trials in cardiac surgery. Background: Previous meta-analyses combining randomized and observational evidence in cardiac surgery have shown positive impact of enhanced recovery protocols after surgery, ERAS, on postoperative outcomes. However, definitive data based on randomized studies are missing, and the entirety of the ERAS measures and pathway, as recently systematized in guidelines and consensus statements, have not been captured in the published studies. The available literature actually focuses on ERAS-like protocols or only limited number of ERAS measures. This study aims at analyzing all randomized studies applying ERAS-like protocols in cardiac surgery for perioperative outcomes. Methods: A meta-analysis of randomized controlled trials, RCTs, comparing ERAS-like with standard protocols of perioperative care was performed. Prospero registration CRD 42021283765. PRISMA guidelines were used for abstracting and assessing data. Results: 13 single-center RCTs, N equals 1704, 850 in ERAS-like protocol and 854 in the standard care group, were selected. The most common procedures were surgical revascularization, 66.3%, and valvular surgery, 24.9%. No difference was found in the incidence of in-hospital mortality between the ERAS and standard treatment group. Risk ratio, RR, 0.61, 0.31, 1.20, p equals 0.15. ERAS was associated with reduced intensive care unit, standardized mean difference, SMD, minus 0.57, p less than 0.01, and hospital stay, SMD minus 0.23, p less than 0.01, and reduced rates of overall complications when compared to the standard protocol, RR 0.60, p less than 0.01, driven by the reduction in stroke, RR 0.29, 0.13, 0.62, p less than 0.01. A significant heterogeneity in terms of the elements of the ERAS protocol included in the studies was observed. Conclusions: ERAS-like protocols have no impact on short-term survival after cardiac surgery but allows for a faster hospital discharge while potentially reducing surgical complications. However, this study highlights a significant non-adherence and heterogeneity to the entirety of ERAS protocols, warranting further RCTs in this field, including a greater number of elements of the framework. Aids to improve understanding of statistical risk in patients consenting for surgery and interventional procedures, a systematic review. Background: Informed consent is an essential process in clinical decision-making, through which healthcare providers educate patients about benefits, risks, and alternatives of a procedure. Statistical risk information is difficult to communicate, and the effectiveness of aids aimed at supporting this type of communication is uncertain. This systematic review aims to study the impact of risk communication adjuncts on patients' understanding of statistical risk in surgery and interventional procedures. Methods. A systematic search was performed across Medline, Embase, PsycInfo, Scopus, and Web of Science until July 2021, with a repeated search in September 2022. RCTs and observational studies examining risk communication tools, for example, information leaflets and audio-video, in adult, age greater than 16, patients undergoing a surgical or interventional procedure were included. Primary outcomes included the objective assessment of statistical risk recall. Secondary outcomes included patient attitudes with respect to statistical information. Due to the study heterogeneity, a narrative synthesis was performed. Results. A total of 4,348 articles were identified, and following abstract and full-text screening, 14 articles, including 9 RCTs, were included. The total number of adult patients was 1,513. The most common risk communication tool used was written information, N equals 7. Most RCTs, 7/9, 77.8%, showed statistically significant improvements in patient understanding of statistical risk in the intervention group. Quality assessment found some concerns with all RCTs. Conclusion. Risk communication tools appear to improve recall of statistical risk. Additional prospective trials comparing various aids simultaneously are warranted to determine the most effective method of improving understanding. Extremely high peritoneal cancer index in colorectal peritoneal metastases demonstrates safety and overall survival benefit in selected patients undergoing cytoreductive surgery and heated intraperitoneal chemotherapy. Background. Colorectal peritoneal metastases are a devastating consequence of colorectal cancer, CRC, with extremely poor prognosis. Patients that can undergo complete cytoreduction by cytoreductive surgery and heated intraperitoneal chemotherapy, CRS/HIPEC, have a markedly improved overall survival. Traditionally, patients with extremely high peritoneal cancer index, PCI greater than 20, are not offered CRS/HIPEC. Methods. We performed a retrospective analysis of our prospectively maintained CRS/HIPEC database and evaluated all patients with CRC peritoneal metastases between 2012 and 2022. We divided the cohorts between those with low operative PCI less than 20, and high operative PCI equals greater than 20. We examined demographic, clinicopathologic data, perioperative, and oncological outcomes between the cohorts. Results. Of the 691 patients who underwent CRS/HIPEC, 289 were evaluable with CRC metastases, 234 with PCI less than 20 and 43 with PCI equals greater than 20. Median radiologic preoperative and operative PCI was 4 and 10 versus 7 and 24.5 in the low and high PCI cohorts, respectively. Operative time was longer, 6 versus 4 hours, and blood loss higher, 500 versus 400 milliliters, in the high PCI cohort. All other demographic, clinicopathological, and operative characteristics were similar. Median disease-free survival, DFS, was longer in the low PCI cohort, 11.5 versus 7 months, but overall survival, OS, showed benefit, 41.3 versus 31.8 months, P equals 0.001 and P equals 0.189, respectively, comparatively with an only chemotherapy strategy. Conclusions. Appropriately selected patients with CRC metastases and extremely high PCI demonstrate similar perioperative safety outcomes in experienced tertiary referral centers. Despite a shorter median DFS, these carefully selected patients demonstrated similar median OS. In hospital outcomes of autologous and implant-based breast reconstruction in patients with diabetes mellitus, a population-based study of 2015 to 2020 national inpatient sample. Background. Breast reconstruction encompasses autologous, ABR, and implant-based breast reconstruction, IBR, each with its own sets of potential complications. Diabetes mellitus, DM is associated with breast reconstruction complications, although most of the studies did not differentiate between the reconstruction procedures. This study conducted a population-based study examining impact of DM on in-hospital outcomes in ABR and IBR. Methods. Patients underwent ABR or IBR were identified in national inpatient sample from Q4 2015 to 2020. A 1-to-2 propensity score matching was used to address differences in demographics, hospital characteristics, primary payer status, comorbidities, and reconstruction staging between DM and non-DM patients. In-hospital outcomes were assessed separately in ABR and IBR. Results. There were 997, 7.68%, DM and 11,987, 92.32%, non-DM patients in ABR. Meanwhile, 1,325, 7.38%, DM and 16,638, 92.62%, non-DM patients underwent IBR. DM cohorts in ABR and IBR were matched to 1930 and 2,558 non-DM patients, respectively. After matching, DM patients in both ABR and IBR had higher risks of renal complications, ABR, 3.73% versus 1.76%, p less than 0.01, IBR, 1.83% versus 0.78%, p equals 0.01, and longer length of stay, ABR, p equals 0.01, IBR, p equals 0.04. In ABR, DM patients had higher respiratory complications, 2.82% versus 1.19%, p less than 0.01, excessive scarring, 2.72% versus 1.55%, p equals 0.03, and infection, 2.42% versus 1.14%, p equals 0.01, while in IBR, DM patients had higher hemorrhage/hematoma, 5.40% versus 3.40%, p less than 0.01, and transfer out, 1.52% versus 0.78%, p equals 0.04. Conclusion. DM was associated with distinct sets of in-hospital complications in ABR and IBR, which can be valuable for preoperative risk stratification and informing clinical decision-making for DM patients. Immediate mobilization in post-anesthesia care unit does not increase overall postoperative physical activity after elective colorectal surgery, a randomized, double-blinded controlled trial within an enhanced recovery protocol. Background. The level of postoperative mobilization according to enhanced recovery after surgery, ERAS, guidelines is not always achieved. We investigated whether immediate mobilization increases postoperative physical activity. The objective was to evaluate the effects of immediate postoperative mobilization in the post-anesthesia care unit, PACU, compared to standard care. Methods. This randomized controlled trial involved 144 patients, age greater than or equal to 18 years, undergoing elective colorectal surgery. Patients were randomized to mobilization starting 30 minutes after arrival in the PACU or to standard care. Standard care consisted of mobilization a few hours later at the ward according to ERAS guidelines. The primary outcome was physical activity, in terms of number of steps, measured with an accelerometer during postoperative days, PODS, 1 to 3. Secondary outcomes were physical capacity, functional mobility, time to readiness for discharge, complications, compliance with the ERAS protocol, and physical activity 1 month after surgery. Results. With the intention to treat analysis of 144 participants, median age 71, 58% female, 47% underwent laparoscopic or robotic assisted surgery. No differences in physical activity during hospital stay were found between the participants in the intervention group compared to the standard care group. Adjusted mean ratio 0.97 on POD 1, 95% C, 0.75 to 1.27, p equals 0.84, 0.89 on POD 2, 95% C, 0.68 to 1.16, p equals 0.39, and 0.90 on POD 3, 95% C, 0.69 to 1.17, p equals 0.44. No differences were found in any of the other outcome measures. Conclusions. Addition of the intervention of immediate mobilization to standard care did not make the patients more physically active during their hospital stay. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.